This is typically a clinic, one of the clinics that we're testing the solution at the moment. It's a small rural clinic. Sister Mercy is the sister in charge at the clinic, and so she will tell you a bit more about what is happening there. This is another example of a primary health. What we've done is we've implemented a basic server at these clinics, electronic health record type system. But first, before we could roll it out, we did basic computer training at these clinics. And this is a picture taken in one of those training sessions where you start with basic computer. I think that is what's heartwarming in this type of a project, is that the people really appreciate it.
More than 10 years experience in the same facility, of which I'm going to present now, is Agincourt Clinic in Bushbuckridge, next to Kruger National Park, near the Mozambique border in Mpumalanga province. Its Agincourt facility is supporting 4 nearby clinics, which having the total populations of 102,295, of which the facility seen patients at around 7,000 to 8,000 per month. This Agincourt facility is a deep rural remote area, which is 90% gravel roads. More people are unemployed. No recreational facilities except sports, which are not even excellent on it. No shopping complexes near the facilities, of which really makes the young generations not to like the area to work there. Agincourt Clinic is a 24-hour service, of which it's operating day and night, and it's run by the following staff: 9 professional nurses, 6 staff nurses, and 5 nursing assistants, 3 administration clerks, and 7 cleaners. The referrals and distances to the hospital, because it's a clinic, we do refer patients to the hospitals where there are doctors, which is 46 kilometers away from the facilities. And how are we taking patients to the facility, to the hospital? We use the emergency services, these are the ambulances, where we call at the central point, of which the turnaround time there is 1 hour plus. They have to reach there. And they also assist us because they queue clients for us. They know those who are coming for refill for the chronic medications, because we do have fast queue lanes there. Yeah, they know that this room is for issue of chronic medications. Maybe this room is for maybe attending the other 5 clinics, and this room is for minor ailments. So they queue patients for us there. So it's so simple. Even the clients, they know where to go.
It's easy to implement technology in this type of environment. The technology part, that's the easy part. But it's how do you deal with the users? How do you, what do they prefer? How do you maintain these solutions in remote areas? So those are the learnings that we want to take away from.
Of the 9 provinces, there are 4,479 clinics. Now, these clinics include mobile health centers and community health centers. Government is the dominant partner who actually provides this healthcare for about 82% of the population, which is about 40 million of the 49 million. This is made up of 9,500 doctors. The remaining other 60% is the private sector, with which the private sector has 25,000 doctors, catering for about 8.5 million people. So you can actually start to see the disparities. When my mother was pregnant with me, she would have had to have visited one of these community health centers, which is clinics, one of these 4,500. So during her pregnancy, month 1, month 2, monthly, she would have had to go to these checkups and basically see that mother's fine and baby's fine up until she has to go into labor and give birth. She would then, as Mercy was referring to, what we call the public emergency services, which is an ambulance. They'd have to call for an ambulance to take her to a tertiary hospital for her to give birth. I would then, when she was fine, brought back to the community, my life would then start again, and basically in terms of my inoculation, my vaccinations, my treatment, in terms of family planning would continue in one of these practices. Yeah, I'm not present today, thank God. And it says I'm a non-smoker, chronic, it gives me my disabilities or allergies. So with this kind of pertinent information, it would make it much easier in terms of ensuring that the patient's information is correct and we're not administering the wrong medication. Also, in terms of home-based care, I could actually choose that and this would basically then go into the system and basically see exactly what drugs need to be medicated, what drugs I should be given, honest chronic medication. We're now introducing cards printed like this, like you would have a medical aid card.
Can people see it in the back? It's got a cell phone built-in with a SIM card, and that connects directly to the service back in Johannesburg. And even if you go out in the rural areas, wherever you have mobile phone coverage, that thing would work. And I think that is one of the challenges that we as SAP is also looking at. You have connectivity. You always have connectivity, but the pipe is very thin sometimes. So the challenge is, technology speaking, how do you build your solutions so that you don't send large chunks of data around the line? I think the results, we are in the final phases of this project. It's supposed to come to an end in February next year. So what we as research generally do is we sell our results internally into our development organization. So our IBU for healthcare, internal business unit for healthcare in Waldorf, and they've now moved to Palo Alto as well. There's been discussions with them all along, and they are aware of the results. So hopefully we can push that into the existing SAP healthcare offering. And then we're also assisting our commercial colleagues or our field colleagues, in particularly Johannesburg at the moment. There are commercial healthcare opportunities in Rwanda and Kenya, and we're supporting them with our results and our field work, basically, on the commercial side of things.